you. So as Miguel noted, my goal for the next 10 or 15 minutes or so is really just to walk you through some of the existing strategies, which are not novel in a sense, but some of the things I may be sharing with you may be a little bit thought-provoking about outside of what you normally envision treating these patients. I'll talk a little bit about outside of the box, thinking about the application of the currently approved therapies for IBD. So my disclosures. All right, so let's talk about what is really the issue at hand and what essentially are the gaps in care for IBD, and to think about, do our current treatment paradigms and our strategies, do they actually able to fill in some of these gaps? One, I'll state the obvious, there is no cure. The other issue is that we have a large primary non-response rate to a lot of the therapies that are approved for the use of both Crohn's disease and ulcerative colitis. We have an even larger secondary loss of response, meaning the durability of particularly the biologics has definitely become an issue for us. A lot of it is likely due to the PK or pharmacokinetic issues that we face when we're managing patients with biologics. We know that even our best therapy can't heal the mucosa in everybody. How far do we push? Are we ready to even think about histologic healing, not just mucosal healing? And certainly, if anyone is using biologics, particularly managing younger adolescents or patients under the age of 21, you know that the biggest barrier to actually optimally managing a child with IBD is the fear of lymphoma. And that remains at the forefront, and no change in whether it's a drug that's offered cheaper or at the level of the biosimilar, for example, the label is not going to change. So we need to actually understand what are the barriers to actually being able to optimize our therapies in patients regardless of perceived or real risk. Just as a quick reminder, there was a question regarding the classes approved for biologics for IBD. These are a reminder of the drugs that are approved for either CD or UC, and it involves the TNFs, the integrins, both Adalimumab for Crohn's disease, and vedolizumab for both Crohn's and UC, and Ustekinumab currently for Crohn's disease. So when you're sitting in front of a patient and you're trying to decide which therapy would best be applied for the patient that's sitting in front of you, there's been a lot of interest, probably before the advent of these other classes, because people were interested in, if I had to choose between Infliximab and Adalimumab for a patient, which one would I choose? So there was historically some comparative effectiveness research done, the latest done by Sid Singh from UCSD, and he specifically wanted to look at, in patients that were naive to anti-TNF or biologic naive patients with Crohn's disease, which therapy would I use and which one has the most evidence for me to use in a patient with Crohn's. What they actually found was that Infliximab had lower risks of hospitalization, abdominal surgery, and corticosteroid use compared to Adalimumab and certolizumab. Sid also noted that Infliximab and Adalimumab patients were more likely to stay on their treatment 6 to 12 months later than individuals on certolizumab. He did not find a difference in serious infections across the anti-TNF therapy in these bio-naive patients, and therefore his conclusion was that Infliximab may be superior to other anti-TNF therapies in Crohn's disease. Well, there was another paper by Mark Osterman in 2014. He looked again at the comparative effectiveness of Infliximab and Adalimumab, didn't look at certolizumab, and he looked at the US Medicare data from 2006 through to 2010. And he looked at patients who were new users of these drugs as of January 31st, 2007. And he looked at disease persistence on therapy at week 26. And what he actually found is that at 26 weeks of treatment, he noted that there was no significant difference between the number of patients who were still on the biologic that they started on. And so his conclusions was it didn't look like which drug you chose actually impacted durability in the short term, meaning out to 6 months. And so therefore, if you look at the paper from Sid, the question is, what is driving this increased durability? And the problem when you're doing these kind of studies is you don't really understand the exact patient that's sitting in front of you, that the choice was made for Infliximab versus Adalimumab, for example. So when it comes to TNF, and I think everyone in the room could probably agree, that it's probably not about which TNF you start with necessarily. It really is about, do I have the right dose of the TNF that I have started? So we all believe that as we start to understand the pharmacokinetic issues related to TNFs, I think we all believe that if we use higher doses or higher systemic doses of biologics, the question is, have we had enough evidence to support that efficacy is tied to immunogenicity and having enough drug levels? And I think Steve Hanauer presented the post-hoc data from SONIC at this meeting that looked at the rate of efficacy in patients in SONIC and whether or not immunomodulators, the addition of the immunomodulators was because it was actually impacting drug levels, or was it important to have two therapies at the same time? And the conclusion was, again, post-hoc, retrospective, take it all for in that context, he actually found that the efficacy of SONIC was more so tied not whether you were on immunomodulator, but whether you had therapeutic drug levels and did not have antibodies. So I think as we explore outright what is the impact of dosing and immunogenicity and PK on anti-TNF therapy, we as a community need to say, are the new therapies that we have for IBD, are they impacted at the same level by dosing and immunogenicity? And will it be easier to use some of these newer therapies because maybe you don't have to use combination therapy? Maybe immunogenicity is not an issue. So I'll walk you through some of this information as we go through the other classes. So let's start with the leukocyte trafficking. This graphic, and I have to thank Miguel for some of these slides as well. The graphic is really highlighting for you the idea that there are multiple ways that cells are actually impacted from trafficking to the gut. Right now, the two therapies that we have that are in this class of anti-integrin or blockage, anti-integrin and trafficking is vedolizumab and adalimumab. Adalimumab only for Crohn's disease, and vedolizumab, as you know, in May of 2014, it was approved for Crohn's disease and ulcerative colitis. I'd say probably the next one that we're going to be looking at is really etrolizumab, which is the beta 7 and also the alpha 4E component of the lymphocytes, and also these anti-MAdCAM antibodies are actually being looked at as well. Those, I think, are probably ones you will be seeing more and more data. I think that the etrolizumab program for phase 3, there's about 7 phase 3 programs planned, so we're going to see a lot of ways that integrids will be used in the phase 3 setting. One of the things that I wanted to remind everybody about the gut's selectivity of what we know about vedolizumab right now really came from the data looking at vaccines. So how did we come up with this idea that when you track specifically alpha 4 beta 7 lymphocytes, how are we to actually understand what it's doing in terms of, is there any systemic effect? Meaning, does the effect of vedolizumab go outside of the gut? And what was interesting is they looked at the vaccine responses. And so when they looked at the systemic response to hepatitis B, what they showed is that if the patient got vedolizumab versus the patient who got no drug, meaning placebo, they both responded to the hepatitis B vaccination in the same way. But when you looked at oral cholera, which is a gut-targeted, obviously, or gut-specific type of vaccine, you could see that patients who got placebo responded and were immunized against cholera, but the patients who got vedolizumab did not mount a response to cholera, suggesting that indeed it is definitely gut-selective. So these were sort of the earlier studies that really helped us understand that we are dealing with trafficking specifically to the gut. The overall programs for vedolizumab were what we call the Gemini programs. There was Gemini 1, 2, 3, and then the long-term extension. Gemini 1 is the ulcerative colitis data. I chose this slide because I think it's the clearest way of looking at whether these therapies are meeting the outcomes, both primary outcomes as well as secondary endpoints. And what you can see for ulcerative colitis, which is why I think, and most of the panel agree, I'll ask them their opinion later, and Miguel can ask us what we think, that we definitely are very enthusiastic about the effect of vedolizumab in ulcerative colitis, particularly in the TNF-naive group. So we can talk further about positioning of therapies, maybe when we talk about how we'll position it in the future with other therapies coming down the pipeline. This is the data for Crohn's. As a reminder, when it actually crosses here in this dashed line, this is just to tell you that there was no p-value significance because it essentially crossed over towards placebo. So as you can see from what I just showed you for UC, although the endpoint of clinical remission, primary endpoint of clinical remission was met, as you can see, it was on the side of favoring vedolizumab. The clinical remission at week 8 and 4, at week 4 and 8 in the maintenance phase were met, and you could see that clinical remission at 80% of the visits, whether it was at an every 4-week interval, at every 8 weeks, did not meet statistical significance. So that led a lot of us to start thinking about where do we position vedolizumab in the space of Crohn's disease compared to ulcerative colitis, and I do think that's really a nice topic for discussion to see how people are using it. This is a slide that looks at the long-term extension. Now, I want everyone to interpret long-term extension studies very closely because these are people who were in the end of the trial, who made it out to week 52, and then are followed to see if they continue to be on drug. Typically, what the point is that if you make it to the end of the actual controlled aspect of the trial and you're well, the durability of this therapy during the extension was very nice. So it was about really saying, if I made it out a year, does my durability on this drug stand true? And that's what we look at when we look at the long-term extension. And this is just to divide up patients who were TNF failures versus those that were naive. And it was just to show you that the TNF failure patients struggled a little bit more than the patients who were naive to TNF, or the total population is just the green, which is the combined. So it looks like durability is quite nice if your patients make it to the end of the study. But I would tell you, you would see this graph for Adalimumab, for Infliximab, because you self-select the patient who's made it out to week 52. The good news is if you make it out to week 52, as I noted, durability is quite strong. The initial package insert definitely has the adverse events described and looking at percentages. It didn't actually we looked at it here differently. This is by Dr. Colombel, which was published in Gut in 2016, and this was looking at per 100 patient years of exposure, which is a little bit of a different way of looking at adverse events. And the one thing that I wanted to point out is that some of the things that were happening, so in the package insert, which suggested maybe more nasopharyngitis or more arthralgias, you can see when you look at it in placebo exposure versus vedolizumab, for example, there was no difference in arthralgias. There appeared to be a similar flare rate of ulcerative colitis. Other side effects, which a lot of people are telling, my patients tell me that there's I think a Warrior, vedolizumab Warrior online blog or something, and it's all about that you can get horrible sinus infections and terrible colds, and they talk amongst themselves in this blog, but when we look at the data, we actually show that there didn't appear to be an increased risk of nasopharyngitis, despite in the package insert, there is notice that it actually had increased nasopharyngitis when you look at absolute percentages. I guess the other point also is the serious infection rate, which is pointed out here, 3% versus 2%. Malignancy, any malignancy in the placebo group, 1% versus 0.2. So this is kind of what I use when I talk to my patients about what their expectations will be, because this balances out placebo exposure versus vedo exposure as opposed to absolute percentages. So I actually like the way that this, I can use this to explain to my patients. This slide is not meant to actually for everyone to remember every post-marketing experience that was published over the years at DDW, but this was just to look at, if we look at the week 14, sorry, it's a little bit malaligned, if we look at the week 14 data versus those patients at week 30, you can see in University of Chicago, I think, had one of the largest outcomes of long-term out to week 30 after the drug initially came out. and it actually showed that the Crohn's response rates were somewhat better than what we saw in the clinical trial. I always like to take clinical real-world experience with a grain of salt because, again, this is more what's happening in the patient that's sitting in front of the physician and not in a clinical trial. And as we know, we learn more from our own clinical experience than sometimes the trials, because if we take the Infliximab record of 24%, 6 months steroid-free remission in ACT, most of us wouldn't still be using that drug because that's not a success story if only a quarter of your patients come off steroids 6 months in of going on this drug. So I can tell you, when you know how to use a drug and you learn about that drug in practice, I think we get better outcomes than what we see. I do want to highlight our work when we did it in pediatric patients, and what was interesting is that we too, at week 14, our pediatric patients who were getting it off-label, of course, but these were patients who were waiting and were failing TNF therapy. They did very well. You could see that our Crohn's patients didn't do as well. So maybe it's different in pediatrics compared to the adult data. So the question is, what do you choose? Like, how do you position these therapies when you have anti-TNF therapy versus vedolizumab? Is it true my list is that short that I'm actually differentiating which patients should be preferentially getting vedolizumab? And I want to bring this up for more of a discussion, is that are these criteria for which we should be sub-selecting patients more carefully for a gut-selective therapy as opposed to what we consider to be a systemic therapy? In terms of age, the reason why I highlight patients who are particularly at risk for serious infections, we know also, I believe Jim Lewis presented yesterday, that corticosteroids in the elderly population, or I should say the aging population, was associated with significant serious infection risk. And I think what we've seen already, and also this was 4 years ago, I remember the group from Leuven actually presented their safety data, and that was really the starting of the discussion of should we be managing patients who are older than 60, 65 differently than patients who are below. And it was just to say that in patients who are on steroids, TNF, and immunomodulators, they really had a very high rate of serious infections, and therefore we need to take that into consideration when selecting our biologic. This was recently published in Advances in Therapy, which we were just looking at from the Gemini program itself, looking at whether or not efficacy and safety differed in those patients in Gemini that were 55 and above versus those that were, for example, less than 35 in the group in between. And we found no significant difference in efficacy, and we also didn't find a significant difference in safety. So perhaps that should be up for discussion as to whether or not you would sub-select a segment of patient who were above 65, and would Entyvio or vedolizumab be your first choice. In terms of thinking outside the box and PSC, the reason why you may have heard some discussion about can we use or should we be preferentially using vedolizumab in an IBD patient with PSC is the background is actually outlined here. We know that PSC IBD, there's aberrant lymphocyte homing, is thought to promote ongoing inflammatory disease. There's actually elevated expression of MAdCAM, and MAdCAM is the actual receptor that actually is signaled where the alpha-4 beta-7 binds to MAdCAM in the liver in PSC patients. There's actually memory T cells with gut homing properties expressed and found in the portal infiltrates. So there's actually a phase 3 trial in Europe going on for PSC with vedolizumab. So that may be another segment of patients who have both IBD and PSC, and again, maybe Miguel could kind of poll us as to whether or not we do sub-select based on that. Gil's going to get into a little bit more about the IL-12/23 pathway, and in related to one of the questions, Stelara or Ustekinumab actually goes after the P40 segment, which is outlined here, and you could see that the P40 is actually involved in both IL-12 signaling as well as IL-23. What's very important to recognize is through the IL-23, this P19, which Gil is going to talk about, because that really is going to be a major future target. It's already a big target in dermatology for psoriasis, so we're going to be following behind the derms in terms of looking at P19. What I do want you to look at is that there's a different type of cell population, different lymphocytes that are actually affected by blocking P40. One of them is the Th17, which Gil will talk a little bit more about why those drug trials failed, and also looking at the Th1, which actually TNF is also involved somewhat in this pathway. So the question is, how will this target be utilized, and do we know already, unlike what I just presented for veto, unfortunately we don't start to have some patient segments yet because it was just introduced into our world in September. So I think we need a little bit more time to start thinking about. I think the only population that we were using it historically on were those patients who got a psoriasiform dermatitis to the TNF, and we were actually using in that group very successfully. So that'll be an interesting topic as well, and whether or not in patients who, for example, have a family history of psoriasis, should this be our first line? You know, there are things that we need to be thinking about when you have more than one class of therapy. And this is just a reminder of the dose, that it's really weight-based, and each vial comes in 130 milligrams. So someone who weighs less than 55 kilos, 2 vials, 55 to 85, 3 vials, or 390, greater than 85, 520. That's a one-time IV infusion, followed by subcutaneous injection every 8 weeks at 90 milligrams sub-Q. Just a reminder of the data we actually have that drove the registration and approval of this drug. What was very unique about the Ustekinumab program in IBD was the fact that there were true induction trials. One of them was in TNF failures, refractory TNF patients, and the other one was in patients who have never seen TNF, or a group of patients who saw TNF historically and were called successes. So TNF responders, but were not on it currently and had not been on it for a while, were able to be enrolled in this trial. So this is what we call a naive population, and this is what we call refractory. And I think all of us could appreciate that if you look at week 6, which was their primary endpoint, you almost have a doubling of the clinical response rate at week 6 in patients who have not seen a TNF, or I should say have not failed a TNF. They may have seen it historically. Patients were randomized at week 8. That's a little bit of a unique piece of the trial, is that the primary outcome was actually at week 6, but they were randomized at week 8. And in terms of the maintenance data, this is the clinical remission data, and you could see that literally there's a doubling of the remission rates in people who have not failed TNF. So that's an important thing to remember as you bring this information back to your clinic and think about what is the sequence of these biologics, and what happens when I start a biologic in the TNF class. Does that impact how my patients are going to respond to their second biologic? In terms of the clinical remission, week 44, which is actually week 52 in most people who would think about it at a year mark, because it's 44 plus the 8 weeks that they use for induction. Just as a reminder, it didn't end at week 44, it actually was at week 52. So sometimes I get confused as well. And this is just showing you the clinical remission at week 54. As part of the trial, there were 3 arms after the induction: placebo, 90 milligrams Q12, and 90 milligrams Q8. And at the end of the day, you can see that there was a slight difference in the Q8 versus the Q12, but because of the impact of CRP as well as other biomarkers, the FDA approved actually a Q8 week dosing. The psoriasis dose is Q12, just so you appreciate the differences. So combined, we actually have 51% of patients who were responders at week 8 were in remission at week 52. Important to always remember the way that things are calculated, and it's not an absolute. In terms of key safety events that we have so far, obviously we will continue to have major safety follow-ups in these patients, but just as a reminder, there does not appear to be any safety signal that stands out as being unique to the STELARA program in the clinical trials. Actually, there was no deaths, there was no cardiac events, and that's important because of the, in some of the psoriasis patients who have a lot of inflammation, they have increased cardiac morbidity, and that was something we were following also in the context of this trial. The PSOLAR database is one of the largest safety databases we have. We have it from the dermatologic literature, which is psoriasis. And I want you to remember that this drug was approved for psoriasis and psoriatic arthritis in 2009, we actually have safety dating back all the way to 2007. And this is just showing you that the rate of serious infection with ustekinumab was only 1.3 per 100 patient years, versus close to 6 per 100 patient years with IFX and 4.3 with other biologics in the dermatologic space. So keep this in mind in the context of maybe the elderly patient again, and whether or not the fact that there is no black box warning for this drug, despite being safety data for almost a decade, is something to be said. As the denominator increases, we have not had a black box warning on this therapy. This is an important thing to remember. The other thing to remember is they are not using thiopurines in psoriasis. So you have to remember and think about what kind of risks are carried by combination therapy, may be negated if you start adding combination therapy. And again, Miguel, I want to hear your thoughts on the role of combination therapy with vedolizumab and ustekinumab. This I shamelessly took from Miguel. This is really a summary because I thought it was so fantastic to kind of frame how all the drugs look across the efficacy and the safety parameters. The mechanism of delivery is highlighted nicely here. There's some extraintestinal manifestations that may be of interest. And I think one of the things that surprised me the most about ustekinumab is, as a reminder, it's approved for psoriatic arthritis. It is not approved for rheumatoid arthritis. A little scientific tidbit is that IL-23 receptor, which is in Crohn's and psoriasis, is not present in rheumatoid arthritis. So can we make the connection that the reason why ustekinumab works in psoriasis and IBD but not in RA is the IL-23 receptor gene? And will we be in place sometime soon to be able to bring genomics into the discussion of what therapy we need to use for which patient? So what are the challenges that lie ahead of us? The challenge is that we're going to be continuously switching. The question is, does the sequence and the mode of action of a drug, does that impact the ability to respond long-term and the durability of our therapies? So I'll end with some of the unmet needs. At the beginning, I identified the gaps. I'm now going to identify the unmet needs. We don't have clear head-to-head studies yet. They are clearly underway, and we are all very anxiously awaiting the results. We need biomarkers of response. We've been trying to look at blood tests. We look at CRP, we look at calprotectin. I think we need a better biomarker that is actually tied to the biology of the drug, and hence why I was suggesting IL-23 may be very interesting. We need to start personalizing. If you're going to have, by 2022, potentially 5 more therapies for IBD, how are we going to know which therapy should be used first in patients to optimize their responsiveness? Because to be truthful, the prevention of bowel wall progression and damage, particularly in a Crohn's patient, the money and the magic is really at the beginning. And if you don't get your first therapy right, you're really looking at putting the patient at risk of bowel wall progression and not changing the natural history of the disease. So that's why personalization is actually a big topic of discussion. And the fact that we need new drugs, even though we have one more in 2016, and now we have 3 classes of therapies, particularly for Crohn's, Gil's going to now give us an introduction to what the future is going to look like. Thank you so much for your attention.